So I'm really excited about our session because we are going to be taking a high-level view looking at psychiatric medications, and we are going to have a group of psychiatrists, a hematologist, oncologist, and a pharmacist all together on a panel to talk about how we are using these medications and what receptors are we targeting for our patients who are seriously ill. So as an internist and a psychiatrist, I recognize that a lot of psychiatric medications, especially in palliative care and hospice, are not being prescribed by psychiatrists. And so I worry about folks who are maybe out of their comfort zone prescribing these medications. And so our hope is that by doing this education, we can increase awareness about the medications, things people should look out for. So I think that moving forward, I hope that they will have a better appreciation for the medications, that there could be lots of drug-drug interactions. Our folks in palliative care often have multiple comorbidities. They're on a lot of medications. And as we continue to add more and more medications into their medication profile, we're increasing the risk of adverse side effects that we don't really want. Also recognizing that our folks are already really sick and symptomatic, so sometimes teasing out some of these psychiatric mental health issues can be a little bit harder in our population because their symptom burden could be from their actual disease and not necessarily from a mental health issue that they're experiencing. There's a lot of education that is needed for primary care doctors and other folks, surgeons, who have patients coming out of surgery or in the ICU, where folks are getting agitated, they're pulling at their lines and they're falling. And then we have people at the end of life who are terminally delirious. And so I'm doing a lot of education almost daily of what symptoms, what's going on, helping folks make a diagnosis, helping them pick the right medications. Because sometimes if they think it's one thing, but it's actually another, they can cause more harm by picking the wrong medication. So doing that initial assessment, finding out what's really going on, getting a really good history, helping the other clinicians to kind of see, this is what I'm seeing as the internist and a psychiatrist, why maybe giving this person a benzodiazepine may not be the best. You may have a really long night on your hands by picking this, whereas maybe this person really is delirious and maybe we should pick something a little bit more sedating, or looking at the symptoms that the person is having and trying to customize and be a little bit more intentional about what we're picking. And so getting my colleagues to think outside the box, think about what else could this be? Is there something that's reversible? Have we really exhausted all reversible causes for this person's behavior? Because maybe medication's not the answer. Sometimes I'm like the grocery store, 10 items or less. The more that we add on for folks, the worse it can be. And so sometimes less is more, especially with folks that they're already having a high pill burden, polypharmacy, they already don't feel well. Adding in another medication may not work all the time. So I think some things that practitioners should be utilizing in their practice is some screening tools, using assessments for delirium. There are some great screening tools that are out there for delirium, also great tools for anxiety and depression, to make sure that when they are selecting a medication that we first and foremost have done our due diligence, history, physical exam, and using the screening tools. I think folks also need to know what constitutes an emergency. If somebody is suicidal or acutely psychotic, that would be a great time to involve a psychiatrist. And I think the other part too is that these are illnesses that can be treated. And just because we're taking care of folks at the end of life does not mean that we should not treat the symptoms and help them have as best quality of life as possible. I hope that through this people take away some clinical pearls, some things to think about, and if they're not really sure or a person's on multiple medications, to call your psychiatrist. It never hurts to get us involved early. We're happy to help. We don't want you to feel stranded trying to sort it out, and we're always here and happy to lend an ear or give some advice through consultation.